So we have just seen that depending on the type of lesion, we are going to have different risks for macular atrophy. And macular atrophy has been redefined. And in fact, I think Dr. Sada is going to talk about all the atrophic changes that account in an AMD. So I just want to point that in some areas we can see areas of outer retinal atrophy and RPE atrophy, so-called RORA now, and other areas they are going to show only areas of atrophy in the outer retina, but a preserved RPE, so-called ORA. But beyond all these atrophic and exudative changes, we are going to have a lot of different signs and OCT signatures that sometimes can mimic subretinal or intraretinal fluid. So we are going to review all these features, or some of them, and see how important they are. And it's important to highlight the utility of eye-track OCT, because we can now go back and see this OCT and repeat again, see how these lesions originate. And this is only been able to see because of the eye-track OCT. So in this case, we are seeing some round hyperreflective structures in the outer retina, and this is called outer retinal tubulation. This was described by Dr. Freund in 2009, but in fact was firstly described in histology by Dr. Curcio in 1996. And thanks to her, we know that these structures are mainly containing degenerated photoreceptors, red and green cones, and also they are enveloped by Muller cells. It's important to know that these hyporeflective structures have a hyperreflective band that characterize these lesions. Those are located in the outer nuclear layer over disrupted or absent RPE. And it's important to differentiate these structures from cysts, because those are not a sign of exudation, but a sign of neurodegeneration. And we also know, thanks to the histology, that the hyperreflective band corresponds to the ELM plus translocated mitochondria. If we follow the ELM, in fact, we are going to see that different shapes are seen in the border of the atrophy, and we can name that as flat, curved, reflected, and scrolling. And we review all these cases with outer retinal tubulation, and we saw that these, in fact, correlate with the origin steps of outer retinal tubulation. So we see that the ELM descent moves from a flat shape into a curved shape, then a reflected shape, and then a scrolling shape. And this is maybe a point of no return in order to have outer retinal tubulation. So this has a lot of prognostic value, especially in patients where we are going to have some therapy, maybe in the future. In these cases with outer retinal tubulations, we also see other signs that may mimic subretinal or intraretinal fluid, as in this area. Sometimes we can really have really complex cases, and we don't know if this corresponds to fluid or not. But this was described by Dr. Jordi Mones as a hyperreflective wedge-shaped band, and it's always located at the edge of the area of atrophy. Always seen as hyporeflective and with a wedge shape. It's also important to know that those correspond to the Henle fiber layer going down to touch Bruch's membrane, so it's not fluid at all. And depending on the tilting that we use or the direction that we use in order to acquire the OCT, we are going to have changes in the visualization of this wedge-shaped band. And we have another wedge-shaped band, hyperreflectivity, described by Dr. Giuseppe Kerkes. And this one is located in the outer retina above areas of geographic atrophy. And sometimes we can have these hyper-reflectivity areas within this area of changes. And we don't know if this corresponds to fluid. It's sometimes difficult to differentiate these shapes with type 1 lesions. And I'm pointing these two hyperreflective wedges because it's really difficult to differentiate both. So Dr. Freund has proposed that this second wedge shape is now called plateau because in fact it's not a wedge, it's more like a plateau, like this mountain. So we are proposing now this other name, the plateau, in order to differentiate the wedge shape described by Moniz in the border and this one. This plateau sign is seen in patients with reabsorption of drusenoid PED. In these cases with drusenoid pigment epithelium detachment, we are going to see that we have progressive thinning of the RPE band. We will have hyperreflective foci going into the intraretinal space. Also, we will have some punctate hyperreflectivities within the area of the PED and progressive reabsorption of the material, but we have this plateau sign at the end with areas within the areas of atrophy, and this has been shown in histology that correlates with the persistence of basal laminar deposits. It's important, the OCTA here, because it shows that there's no flow signal at all in these cases, so it's really easy to differentiate this plateau sign from type 1 lesions with, by using OCTA. So in cases where we have neovascular lesions, of course OCTA is really useful, but sometimes we have really complex cases, as this fellow eye of this 72-year-old female. We have multiple areas of atrophy, and we have OCT signs with some subretinal kind of fluid, some subretinal hyporeflectivities, and also intraretinal cysts. So we sometimes don't know if we have some neovascularization or not. And it's really useful to really not only use multimodal imaging with near-infrared and multicolor, but fluorescein angiography is not going to be really useful in these cases, but we can use OCT angiography and really raster all these lesions, and we are going to see that in this area of plateau we have no flow signal at all. So these cystic changes are related to the epiretinal membrane that this patient has, and this plateau sign has no exudative component. So in conclusion, we see that some OCT features may mimic intraretinal or subretinal fluid, as we have seen, the outer retinal tubulation, the hyperreflective wedge, and the plateau, but they all now correspond to exudative changes in AMD cases. And I want to thank Dr. Kurch and Dr. Bailey-Front because I have been working with them in all these OCT features and the clinical pathological correlations. Thank you so much.